Okay, here's the video lecture for type 2 diabetes. So make sure you put your name there. Okay, basically what's going on is you're looking at insulin, and the function of insulin is it's released by the pancreas, and its function is to open up receptors. So it's like a key that opens up receptors that allows glucose to travel into the blood, or travel from the blood into the cells that will actually use the glucose, and thereby it will lower the blood sugar levels. So blood sugar levels go up, and that will cause insulin to be released. The insulin will cause the sugar from the blood to go into the actual cell so that it can do work and things like that. So the basic etiology of diabetes, and we'll talk mainly about type 2 diabetes. So if the blood sugar levels are continuously high, insulin levels will also be continuously high, and the receptors to insulin will become less sensitive. So the insulin levels or the blood sugar levels can rise because we eat too much sugar or carbohydrate type foods, or a lack of exercise will keep it from going down like it should. This will cause blood sugar levels to be higher on a chronic level. This results in more insulin being released, and eventually the pancreas will become fatigued and stop releasing insulin. This may or may not happen in individuals with type 2 diabetes. So some type 2 diabetics will need insulin, some type 2 diabetics will not need insulin. Some type 2 diabetics just have a high fasting blood sugar, but they still are producing insulin. Other type 2 diabetics are not producing insulin and need to take insulin through a shot or another mechanism like a pump. Increased insulin and blood sugar levels will lead to deterioration of the blood vessels, and several studies have demonstrated that diabetes and prediabetics do not develop, prediabetes does not develop until the beta cells fails to compensate appropriately to peripheral insulin resistance state. So there's a few videos. What I recommend is that you go to YouTube and you look up multiple videos, especially as a group in a class. This is a little bit easier and a little bit better because you guys can tell each other whether a video was particularly good or particularly bad. And generally what I find is that you need to watch a few videos to really get the gist of whether or not you're understanding the material or not. Are all these videos saying the same thing, or are the videos saying something different? Can you tell me or could you write down what the video is talking about? I think that's helpful too. So if you can say, okay, this is the role of insulin, this is how the etiology of type 2 diabetes, if you could say those things, then you probably know the material. If you can't, but the video just makes sense, then you probably don't have enough of an understanding yet. So the mechanisms for the complications. So what I did was I searched, does high blood sugar damage blood vessels? And I got this website. And generally, I read the article or I read the information that was associated with this website, and I didn't really understand all of it. However, these are the things that I did get out of it. And what I got out of it was high glucose levels reduced the levels of the powerful vasodilator nitric oxide, NO, in blood vessels. This is the same nitrous oxide that they talk about in various supplements that cause vasodilation. A shortfall that increases the risk of high blood pressure and eventually narrows down the arteries. High blood sugar increases a protein which then competes for the nitric oxide synthase site. Thereby less nitric oxide is produced and the blood vessel is less able to dilate properly. So it's affecting the integrity of the blood vessels is what's going on. And by looking up this stuff, you see that there is a mechanism. You may not fully understand the mechanism. Most people will not understand the mechanism, but it's important to kind of realize that there is a mechanism, and this is pretty well established in science. So some of the complications that can occur from type 2 diabetes, coronary artery disease is the big one. That's the number one complication. For the kidneys, it's nephropathy, can lead to kidney failure. For the eyes, retinopathy, which can lead to blindness. in the nerves, neuropathy, which leads to numbness and tingling in the extremities, mainly the feet. I would imagine it happens to a certain extent in the hands as well. But there's generally a decreased circulation, which affects the individual's ability to heal. And neuropathy is also associated with an individual getting a wound. The individual doesn't realize that they have a wound that they need to take care of, usually some sort of blister or callus or something along those lines. And then they let it go and they don't take care of it, and eventually it gets infected, and that can lead to amputations and gangrene and infections where the tissue just deteriorates and is no longer viable. So symptoms of type 2 diabetes. Often there's no real symptoms of type 2 diabetes. So the individual has high blood sugar, but that really doesn't have symptoms in and of itself. So the only way to determine if you have type 2 diabetes or prediabetes is by getting a fasting blood sugar sample taken. It's fairly easy. You go to your doctor's office, but there's also a lot of glucometers on the market that many diabetics will have, all diabetics should have. And if you just get up in the morning, test your blood sugar, that's also giving you an indication of what your fasting blood sugar would look like. And if you see that it's consistently high, then the individual should go to their physician and get that further evaluated. These are the parameters for diabetes. The main one that we look at is the fasting blood glucose testing. There's also the oral glucose tolerance test. This is where you drink a super sugary, syrupy drink. That's just pure sugar, pure glucose. And then you're looking at what happens to the blood sugar over a couple hours' time. Does it go back down to a normal level, or does it remain elevated? And then there's also the glycosylated hemoglobin as well that diabetics will check. But the fasting blood glucose is really the most common. So type 1 diabetics have the following symptoms. So if you have pancreatic failure, then those individuals would also have these symptoms. Again, that may or may not happen in type 2 diabetes. So in type 1 diabetes, the individual has an autoimmune response where the pancreas, the beta cells in the pancreas are destroyed. So the person's ability to produce insulin is essentially destroyed. So in those individuals, it becomes critical that they receive insulin from an exogenous outside source. So they will have a pump that they'll wear on their around their stomach somewhere, or they will get insulin shots. And there's many different types of insulin as well. Some of the symptoms that you'll have from that will be potentially increased urination, increased thirst, weight loss, increased hunger, blurry vision, feeling tired. What happens is sometime after the onset of the disease, typically the child will be sick. The parent will not necessarily know what is wrong with their child, but they know that these symptoms, though they seem pretty benign in and of themselves, you can tell that there's something very wrong with their child. So they will go to the emergency room or they will go to their physician to get these things checked out. If it goes on without being checked out, the individual can go into a diabetic coma, and that could be potentially fatal. But I think in most instances they kind of figure it out before it gets to that point. And though these symptoms seem ambiguous, it's just as I stated, they'll be very sick. So if a type 2 diabetic has these symptoms, they've probably had type 2 diabetes for a while, and they may also experience these symptoms as well. But again, that may or may not happen in the type 2 diabetic. So there's also other types of diabetes. I've already mentioned the type 1 diabetes. I just put the basic mechanism there. There's gestational diabetes. So it's basically type 2 diabetes that occurs during pregnancy. The pregnancy is a physiologic stress on the body. So once the so during that time, the individual becomes diabetic, but once the child is born, the diabetes goes away. For those individuals, they are at greater risk of becoming type 2 diabetics later in life. Diabetes insipidus, it's due to a hormonal imbalance. It's characterized by excessive urine production it's really very different from the type 1 or gestational or type 2 diabetes. So the general lifestyle treatments, and we'll talk about this and the mechanisms a little later, but eat healthy, more fruits and vegetables, more whole grains. You can put legumes and nuts and things like that into the mix as well. Exercise, at minimum, regular, moderate exercise on a regular basis, pretty much every day. Get checkups, monitor your glucose, especially if you're adjusting your lifestyle, and especially if you're a new diabetic and you're trying to figure out what's going on with your blood sugar. Manage stress, stop smoking, and also make sure that your alcohol consumption is moderate. So this kind of goes to show the effects of lifestyle and obesity on type 2 diabetes risk. So we have the one group, the people whose relative risk is 1, and they are the fit and normal weight individuals. So what you can see is that as we look at fitness, and we compare the fit normal weight to the unfit normal weight, and we compare the fit overweight to the unfit overweight, and especially the fit obese individual to the unfit obese individual, that diabetes risk is significantly decreased with activity. So, but what we should not forget is that obesity and weight in general is also a very important determinant. So even the fit, or the unfit normal weight individual is really at a lower risk than the fit obese individual, and it's pretty much at the same risk as the overweight fit individual. So it's important to keep both of those characteristics in mind. So the different treatments with medication, you have insulin. You have various different types of insulin, short-acting, long-acting, many different kinds. You have these different medications. So a great variety of different things. I don't know how to pronounce any of these, or I don't know how to pronounce most of these, but pramidlinitide, that's the best I can do, is injected drug used before meals, and it works by delaying the time your stomach takes to empty itself, and thereby reducing glucagon secretion after meals, and this lowers blood sugar levels. It also has modest effects on the appetite. Alpha glucosidases inhibitors. These medications help your body break down starchy foods and table sugar. This effect lowers your blood sugar levels. For the best results, you should take these take these drugs before meals. Biguanides, they decrease how much sugar your liver makes. They decrease how much sugar your intestine absorbs, making your body more sensitive to insulin. They help your muscles absorb glucose, and the most common is metformin, and that's a very common drug that has been around for a long time. Dopamine agonists. Dopamine is usually the hormone associated with feeling happy, and it's known to. It's not known exactly how it works to treat type 2 diabetes. It may affect rhythms of the body and prevent insulin resistance. DPP-4 inhibitors help the body continue to make insulin. They work by reducing blood sugar without causing hypoglycemia. These drugs can also help the pancreas make more insulin. So it kind of helps stimulate the pancreas. Glucagon-like peptides. These drugs are similar to the natural hormone incretin. They increase beta cell growth and how much insulin your body uses. They decrease your appetite and and how much glucagon your body uses. They also slow stomach emptying. These are all important actions for people with diabetes. Meglitinides. These medications help your body release insulin. However, in some cases, they may lower blood sugar too much. And generally, what's going to happen is the physician, the endocrinologist, they're going to have drugs that they like, that they've seen success with. So they may opt for that medication over another medication, and they'll see how the individual responds to the medication. And if they have an idea of what's going on with this individual, are their insulin levels low, then maybe they need to stimulate insulin production. If it looks like it's a sensitivity issue, and a lot of times the physician is not really going to know. So they're going to do their best guess. They're going to adjust the amount of medication that an individual takes to try to get to that right dosage to help keep blood sugar levels normalized. But really the key is to make sure that people keep doing the diet and exercise. The diet and exercise has really been the most effective mechanism to lower blood sugar. Sodium glucose transporter inhibitors. These drugs work by preventing the kidneys from holding on to glucose. Instead, your body gets rid of the glucose through urine. Another thing that you can see is there's multiple different mechanisms to try to lower blood sugar or to increase insulin production. So again, the physician and the patient will work with the patient to kind of mix and match what's the most effective treatment for that individual. Sulfonylureas, these are among the oldest diabetes drugs. They work by stimulating the pancreas. With the help of beta cells that cause your body to make more insulin, and thiazide, whatever. These medications work by decreasing glucose in your liver. They also help your fat cells use insulin better. That sounds great. And in a study, they found that that drug worked just as well as diet and exercise. But what they also found was that these drugs come with an increased risk of heart disease. So one of the big points is you're trying to reduce your risk of heart disease, which is the number one complication for type 2 diabetes. And now you're giving them a medication which may reduce their diabetes, help manage their diabetes, but it's increasing their heart disease risk. So you're still back to square one with this medication. And I think it's used much, much less than it was before. So the drug was called Avandia. That was pretty common for a while. Looked like a big hit, but it really kind of has fizzled to a certain degree. If your doctor gives you one of these drugs, they will watch your heart function during treatment. And if they see that your heart is functioning well, then maybe they keep that. But it's definitely used less than it was before. The different surgeries, there's no real surgery to manage or address type 2 diabetes. The big surgery that you can think of is bariatric surgery, so stomach stapling, obesity surgeries, a bunch of different types. We'll talk about them in more depth in the obesity section. But what they find is that by having that surgery, it reverses type 2 diabetes often while the individual is still in the hospital. And what that tells me is that by severely restricting your food intake, as well as trauma associated with the body, and the individual has to heal associated with that trauma that takes energy, that will reduce will improve your insulin sensitivity and help to reduce your type 2 diabetes. So it kind of again shows you that, hey, we've kind of taken a drastic measure and forced the individual to not eat as much, and that has had pretty immediate effects on managing the diabetes. So when we go to the epidemiology, the thing that I was looking at was, okay, how many people have diabetes and what do the projections look like in the costs? So in 2015, about 30.3 million, or really what's more important to me is 9.4%, so close to 10% of the population had diabetes. And most of that was type 2 diabetes. So some had type 1, but really most of it was type 2. It's the leading cause of blindness, kidney failure, and lower leg amputation. So if you have diabetes, it doesn't necessarily mean that you will go blind or have kidney failure or your leg will be amputated. But if you go blind or you have kidney failure or you have lower leg amputation, it's most likely going to be due to diabetes. Now, there's other causes that will result in these things, but in general, the most likely cause will be type 2 diabetes, or diabetes in general. Uh, Diabetes rates are expected to double or triple by 2050, and approximately a 50% increase by 2030. So these numbers of 9.4% will continue to go up. And as the obesity epidemic and the numbers associated with obesity are getting higher, and the people that generally the people that were born in 1980 and beyond, as those individuals reach the age of 40, 50, we can just expect the rates of type 2 diabetes to continue to increase. A lot of those people, they're knocking on the doorstep of type 2 diabetes. They just have not gotten sick yet. Give them enough time, and they will get sick. Some of them have already gotten sick. But generally, when you're young, there's a good chance that even if you lead an unhealthy lifestyle, you are not necessarily sick yet. But by the age of 30, especially 40, 50, the chances that those individuals will become type 2 diabetics will be much, much greater. And that's what you're going to see in these years 2030, which is really just a little over 10 years away. And even 2050, that seems like a world away, 30 years away. Wow. I'll be 80, close to it. But for you guys are going to be probably in your 50s, somewhere around there. And it's going to be something that really affects healthcare and health insurance costs and things like that. And it's coming. There's no sign. There's nothing to show that this trend is going to go away. So diabetes rates are also higher in minorities, lower socioeconomic status, and older individuals, as is true for a lot of diseases. We see that if you look at 20 to 79-year-olds, again, this number is a little different than the previous number of 9.4. Wow, that worked well. But it's fairly close. It's 10.3. And these are the general rates of type 2 diabetes. And those rates are fairly high. When I was in graduate school, late 90s, the rates were about 5%. So they've essentially doubled since the mid to late 1990s. When you look at type 1 and type 2 diabetes in children, I think this is interesting to see that when you look at the children under 10, the rates of type 2 diabetes are extremely low. And that's what you would expect to see. But when you look at 10 to 19, you see that the rates of type 2 diabetes in proportion to type 1 diabetes are fairly high. In many cases, the rates of type 2 diabetes are greater than the rates of type 1 diabetes. So just to go through it, we have all races, ethnicities, non-Hispanic white, African American, Hispanic, Asian Pacific Islander, and I would say these are the American Indian, Inuits, Alaskan Natives, those types. The total cost right now is approximately $245 billion. So when you look at, we have inflation and things like that, but you have a doubling or tripling, what that's going to do to the cost of, as I've mentioned before, my state health insurance policy for the family is about $20,000 a year between what I pay and what the state of Tennessee pays. So, and that's with these types of numbers. Again, you're looking at other disease states as well. But if these numbers start to double and triple, a health insurance policy, I don't think could go from 20,000 to 40,000 or from 20,000 to 60,000. So it's definitely going to be a problem, and I'm going to deal with it to a certain extent. But definitely, you guys will be dealing with it as well in the coming years. So it's going to might affect you positively in that you have an increased job market. That would be good for you. But as far as health insurance costs go, it's going to significantly stress the system. So the mechanisms of how lifestyle mechanisms or lifestyle modifications work. So lifestyle was mentioned earlier, and unlike other chronic diseases where medications and surgeries play a dominant role in treatment, lifestyle modification should be the main treatment mechanism for the prevention and early stage type 2 diabetes. So if your blood pressure is high, you take a medication and then you do in coordination with lifestyle, but you realize that the medication will have a much greater effect on your blood pressure than necessarily the lifestyle changes. Same thing with cholesterol. If you have heart disease, you may very well get a stent procedure or a coronary artery bypass procedure. That's the main thing that we go to. For type 2 diabetes, the main thing we should go to is lifestyle changes. A healthy diet, they will have anti-inflammatory properties, antioxidant properties, as well as these will also decrease the spike in blood sugar and the insulin released associated with simple carbohydrate consumption. So you're bringing less sugar into the system. When we're looking at exercise, I have this this article, as I mentioned before, and you're looking at mechanisms. You look at this article, and good luck understanding a good bit of it. However, what you realize is that there is a specific mechanism by which exercise works, and I think that's important to keep in mind. What exercise will do is it'll activate these GLUT4 transporters. Insulin will also activate these GLUT4 transporters, and these GLUT4 transporters are located within the cell. And as the individual exercises, or if insulin is released, these GLUT4 transporters will move to the cell membrane, so to that outer surface of the cell. The GLUT4 transporters function to bring glucose into the cell. Insulin will activate the transporters. Both mechanisms will function to lower and control blood sugar. So essentially with exercise, you're not using insulin to bring, or much less insulin, to bring that sugar into the cell. The exercise itself will provide a mechanism to bring that glucose into the cell. So it spares insulin to a degree. All exercise is good. Longer duration and or higher intensity is better concerning this mechanism. So when you're looking at strength training is good. High intensity interval training is fine as well. If the person cannot do that and they do more longer duration, moderate activity, that's fine as well. A lot of different ways to achieve this goal. And then exercise will decrease inflammation associated with insulin signaling. So that's again an added benefit. So here we're looking at insulin sensitivity and participation in vigorous physical activity. So we see that the more 5 or more times per week that individual engages in vigorous activity, the more sensitivity that they will have to insulin. So other lifestyle modifications, mindfulness and mindfulness and prevention. Mindfulness can be considered to be any activity which will aid in stress management. So there's a lot of different ways you can do it. Meditation would be one typical way. If you wanted to do yoga to achieve these goals, that would be fine as well. The activities will aid in decreased inflammation and oxidative stress. The mechanism is through a downregulation of genes implicated in inflammation. So you're decreasing the inflammation that your body will create. And generally, that's a good thing. I think it's important to realize, and I'll just mention it real quick, that if people are involved in excessive amounts of exercise, that will increase inflammation. So there's a sweet spot of how much exercise you should do. Generally, people will not get into those extreme levels of training, but those extreme levels of training are not necessarily good for you, and they will increase oxidative stress. Smoking and alcohol will also increase oxidative stress, inflammation, and the production of free radicals. Alcohol, moderate use has an anti-inflammatory response. Greater use will increase pro-inflammatory cytokines. And I think this is, with a lot of different substances that we don't really know the effects of, but a small usage of substances will decrease inflammation or has had good effects on inflammation. But generally, if you're looking at large consumption of these materials such as alcohol, that's going to increase inflammation. So one big key is also monitoring your blood sugar. You want to keep making sure that your blood sugar is normalized and that you're not having big spikes and big drops in blood sugar. So monitoring it on a regular basis is pretty darn important. Also, regular checkups to catch anything early. And then if an individual has an infection or has a wound, they can get that treated and taken care of in a timely fashion. Genetics also plays a strong role in type 1 and type 2 diabetes. So two people, two young people may lead equally unhealthy lifestyles, and the one becomes a type 2 diabetic at the age of 20, and the other individual becomes a type 2 diabetic at the age of 40. That is the effect of genetics. Some people will be more prone to becoming type 2 diabetics. However, you should still lead a healthy lifestyle, and that will decrease your risk no matter what your genetics are. And also, environment will play a key role. Pollution and global warming would likely have minimal effects, but living in an environment filled with low nutrition, high calorie foods, decreased opportunity for exercise will increase your risk. I think a big factor in this as well is what is your social structure, what are your friends doing, as well as if you're a child, what are your parents doing, and how are they instilling certain lifelong lifestyle habits into the child. That's going to be very important. So we're looking at this a little bit the opposite. So these are what we looked at up till now are what are the things that are going to cause you to become a diabetic. Now we're looking at, okay, you already have diabetes. How does that affect my life? So you first have to consider what these people generally look like. Generally, they're going to be obese, or not even what they look like, but what are their general characteristics? They're going to be most likely obese. They're going to have a poor diet. They're going to be inactive, and likely that they have some level of a genetic predisposition. Diabetes takes obesity to the next level, where you are not only carrying extra weight, but you need to also manage physiologic complications. So it's kind of a vicious cycle. The individual has extra weight. They've gotten to this habit of eating poor quality foods. Then they're less likely to exercise, and that's going to lead to increased blood sugar, increased diabetic complications, and things like that. So it's a vicious cycle that it goes into. Some basic issues: much greater medical costs. They have to pay for medications, doctors, treatment as a result of those complications. So the diabetes is fairly expensive. And if they don't take care of their diabetes, then they get complications, and the complications are very expensive to manage and treat. A hospital stay, amputations, bypass surgery, dialysis, all those things are very expensive to pay for. So if you're not doing the things you should, you're definitely going to get hit even more, but a little bit later on. Depression and possibly self-loathing. So the disease will hasten your death, and it's in large part due to lifestyle choices the individual made. So not a guarantee, but likely. And this can produce definitely a level of depression. I would say probably a level of self-loathing. Like, how could I let this happen to myself? How could I let my life get out of control in this manner? And I'm not saying everybody has that, but I would imagine there's a segment of the population that probably does occur. Changing your lifestyle is difficult. You've gotten into certain lifestyle habits. Now you're trying to change those. It's just not easy. Darn it. So decreased ability to complete tasks that have a physical component. Again, it's hard to tease out. Is this because of obesity, or is it because of the diabetes? I think I already mentioned this. Let me see. Oh, I just repeated these basic characteristics. And moderate exercise is recommended with the hope that intensity and duration will be increased over time. And that's really the key. If somebody's going to engage in long-term moderate physical activity, that's fine. They will incur most of the benefits associated with exercise, and they'll decrease their risk for type 2 diabetes, as well as decrease the risk of orthopedic injuries and things like that. And the exercise will be better tolerated. So a lot of positives associated with moderate activity. If you can do more, potentially that's going to be better, and that's going to help manage your diabetes a little bit more. But sometimes that's feasible, sometimes that's not. The effects on exercise, the individual will need to start slow and they will have a generally decreased capacity for exercise independent of the diabetes status. The goal should be to get into a regular exercise regimen, and both strength training and aerobic training will be beneficial. And with that said, really strength training, aerobic training, balance training, flexibility training, a well-rounded exercise program is key. If the person is just engaging in part of that, I think that's a big step in the right direction as well, especially if they're if they're actively using their muscles. So something like flexibility should be looked at as getting the individual ready to do higher level of activity. I don't think that the individual will have much physiologic benefit associated with flexibility from a glucose management perspective. But if that gets you ready to do other types of activity, that's great. When you look at strength training, aerobic training, core training, any of those types of things, if the individual has a strong preference for one or the other, that's what you should center the exercise routine around. And it's a matter of creating an ideal workout versus creating versus them doing anything at all. And the key is that they do anything at all. And if they're doing regular strength training, they've gotten into a good routine, then yes, and you see that their aerobic aspect is lacking, then maybe you add that in and you suggest to do more aerobic activity, and that's great. But if they're doing strength training and then you tell them to do aerobic, and now they just quit exercise altogether, you're better off with them just having done the strength training alone. So you've got to kind of walk that fine line. Addressing the complications, we already mentioned this, but now we're looking at it from the perspective of how these complications affect your ability to exercise. So neuropathy, their balance will be affected. You also have to monitor wounds on the legs and feet. And of course, if they have an amputation, that's going to affect your ability to exercise. The individual, if they have a wound, they should work with their healthcare provider to address the injury. However, this will not be the exercise physiologist, so it won't be you in most instances. Exercise to tolerated levels. Nephropathy, these people will be severely debilitated. They will not be able to do much. You're going to exercise to tolerated levels. So in these cases, when I mentioned before to kind of push the individual, that is for the type 2 diabetic that is newly diagnosed, doesn't have any complications. You figure out what you do. Once they have these complications, everything changes and the complication becomes the priority or the driving force within the exercise prescription. And you're making sure that the exercise does not make the complication worse. You have retinopathy, which is blindness. Anything that's going to increase the pressure on the eyes, so a prone exercise or decline exercise, so a standard bench press or definitely a decline bench press would be definitely off the table. But even like a leg press where the individual is laying down, I would be very careful with doing those types of activities as opposed to doing more of a stand-up type of a leg press. Heart disease, exercise is tolerated. It's important for all these people to exercise, but you're trying to make sure that the exercise is not making things worse. The individual will need to start slow and will have a generally decreased exercise capacity. I think I already had this slide. I don't know if I'm going backwards or if just Okay, looks like I just went backwards. The general research on type 2 diabetes. When I did a PubMed search and I just put in type 2 diabetes, I came up with essentially 150,000 articles. And 27,500 articles were review articles. So they looked at studies and kind of put everything together. One of the biggest studies as far as exercise is concerned and lifestyle was this diabetes prevention program. Clinical trial that found that 58% risk reduction with diet and exercise versus a 31% reduction for metformin. And all of this was compared to the control group who received just education. And what you see in most programs is people will either do the metformin, take the medication, or they will do the education classes along with the metformin, and that's still not as effective as doing regular diet and exercise. So it's important for these individuals to do the diet and exercise. And this was kind of the results of that study. So again, the reference group is the placebo, and they are one, and then you can see that it was reduced for these other groups. So different potential study designs, and I want you to either find study designs that address these different, or studies that address these study designs, or put together something like this where you say, okay, this is the different types of study designs and what would be examples of potential studies. So cross-sectional, how many people with type 2 diabetes have a complication? Just give a survey to everybody with type 2 diabetes, see what happens. Determine the complication rate. You could also ask them questions about diet and exercise and see if there's some sort of correlation that's going on there. That would be fine too. Case control, how many people with an amputation under the knee, not the the knee, were the result of a diabetic complication. So you take all people that have a amputation under the knee and you give them a survey to see, okay, well, how much of this is related to diabetes? Cohort study, you take a bunch of people that are physically active as young adults, and you look at their risk of getting type 2 diabetes later in life. And again, that would take a long time to do that study. And then a clinical trial, an example of that would be doing a 10-minute high-intensity interval training and figuring out whether it was more or less effective than a 60-minute walking when examining various parameters for type 2 diabetes. You'd want to make sure that the volume of activity was similar. So a lot of times what you see is it's just the volume of activity. Sure, you can do high-intensity interval training in a shorter amount of time, and that might look attractive to many individuals. But is it the fact that you're just doing a certain volume of activity that's the key, or is it specifically that it's high-intensity training that is more the benefit? And you want to kind of figure that out. And that's it.